Hi, everyone. It looks like people are getting connected to audio. Let's just give it one more minute. Okay, it looks like most people are connected. Um, so we'll get started. So thank you for joining us for Advancements and Barriers in Treatment of Perinatal Mood and Anxiety Disorders, Perspectives from a Clinician Scientist, hosted by the Society for Health Psychology's Women's Health Interest Group and co-sponsored by the Society of Clinical Psychology, APA Division 12. I'm Jessica Clifton. I'm co-chair of the Women's Health Interest Group along with Dr. Christina Hood. And before we begin, we have a few items to share. First, this is an all SFHP virtual presentation. They're offered as a free benefit of membership in the Society for Health Psychology. Please invite your colleagues and students to join to ensure unlimited access to future presentations and other society benefits. This webinar is also eligible for one continuing education credit under the Society of Clinical Psychology's Division 12 sponsorship. CEE evaluation information will be sent via email to all who attend the full presentation shortly after the webinar. We will leave the evaluation portal open for 1 week until 5 p.m. Eastern on Friday, September 27, 2024. CEE certificates will be sent via email within 5 to 10 business days after the evaluation period closes, and using the email in which you enrolled in the session. All participants are invited to submit feedback via the evaluation, even if you're not seeking credit, because we like to get that feedback. Now I'm excited to introduce today's speaker, Dr. Britton Mahaffey. Dr. Mahaffey is an assistant professor of psychiatry and behavioral health at the Renaissance School of Medicine, Stony Brook University. She also serves as the program director of dialectical behavior therapy and the Women's Mental Health Integration Lead at the Mind Body Clinical Research Center. Her research and clinical work focuses on treating anxiety and stress disorders, especially during life transitions like pregnancy and postpartum. She's board certified in both dialectical behavior therapy and perinatal mental health counseling, and she's passionate about expanding access to quality mental health care. Welcome, Dr. Mahaffey.
Thank you so much, Jessica. Again, I so appreciate you all having me today. And I'm really looking forward to talking with you a bit more about perinatal mental health. So I'm going to see if I can get my screen sharing going. Hopefully it cooperates with me. And Jessica, if I can just ask you, can you see my slides okay?
Yeah, it looks good. Can you put it in presenter mode?
Oh, it's not. It's showing in the wrong mode. Hang on one moment. Try that one more time. How about now?
Yes.
All right, perfect. Okay, so just a couple of disclosures first. I'm going to talk to you guys a little bit about some of my research in this area, especially as it pertains to clinical practice, and that some of that work was supported by the NIH, specifically the National Institute of Child Health and Human Development. I also currently have some funding from the National Institute, or National Center, excuse me, for Complementary and Integrative Health and the National Institute on Drug Abuse as well. So just broadly, some of the objectives for what we're going to be discussing today. We're going to talk about really the prevalence of perinatal mood and anxiety disorders. We're going to get into a little bit about risk factors and who we need to be really specifically paying attention to. We're going to talk about, this is a really challenging to engage population, just due to, the stressors that they're going through in this time in their life, in large part, and especially financial barriers as well. So we'll talk about why it's so hard to get folks into care. We're going to go over a bit about the current evidence base for psychotherapy. I'll mention a couple of new medications that were developed. Again, I'm a psychologist, not a psychiatrist, so I will do my best as a scientist in terms of what I understand about these clinical trials to share that with you. And I still would encourage you to talk further with a psychiatrist colleague if you have questions about these medications. And then I will talk about what I think are some really important future directions, both clinically as well as I think from a broader legislation and advocacy perspective, that I think we can also serve an important role in. As a reminder to myself, I have here a note on terminology. I'm going to be using the term women and mother and mom throughout. I do just want to recognize that not everybody identifies with that terminology, so I may also sometimes use the word birthing parent. I will also mention I'm going to be focusing primarily on people who we typically would identify as women here and mothers. That does not mean that men and that non-birth parents are not affected by peripartum mental health conditions, especially as we see more men taking on caregiving roles in the home. An increased availability of parental leave as opposed to just maternal leave. I think we're going to see increasing rates of mental health conditions in fathers and non-birth parents as well. So I just want to acknowledge that, although they're not going to be my focus here. So most of my work and my interests really focus on pregnancy, this kind of antenatal period, as opposed to the postpartum period. Historically in the US, we've been very fixated on postpartum depression. And I think that that's really a trap in a number of ways. Because again, many of the mental health conditions, and I'm going to show you guys some statistics here in just a minute, the conditions that we're most concerned about for most people either start during pregnancy or even prior to conception, right? One of the biggest risk factors we'll talk about is your personal history in terms of your mental health. So we'll talk a bit about some myth busting here around kind of the hormone theories of peripartum mental health conditions. And I think that's part of the reason we haven't focused as heavily on pregnancy and even the preconception period as we should have. So maternal mental health problems, you will see certain groups now some groups are still using the term PMADs. Some programs have gone to more broadly using the term maternal mental health problems. The reason I think you'll see sometimes the term maternal mental health problems used is because we want to also acknowledge that psychosis and other more severe bipolar disorder, other more severe mental health problems can occur during the peripartum. I'm really going to focus more on depression and anxiety here, so you will see me use the term PMADs, which is peripartum or perinatal mood and anxiety disorders, because they're more common, okay? And they're more likely to be what we're going to see in practice, and so we really need to focus in on those. Doesn't mean the other conditions aren't important, but we need to be aware of kind of base rates here in our thinking. So you'll see varying statistics. Here you'll see ACOG, which is the American College of Obstetrics and Gynecology, indicates 1 in 7 women may be affected, and they're specifically talking about depression. When we include anxiety, that goes up to 1 in 5. You'll see, again, different numbers for non-birth parents, but often we'll talk about 1 in 10 for fathers or non-birth parents. I just want to emphasize here, though, that if we're going to talk about the difference between incidence and prevalence, so incidence being onset, that if somebody is going to have incidence, if they're going to have onset of a new mental health condition in the peripartum, it's more likely to actually occur during pregnancy than it is during the postpartum. So why are we waiting to provide care until the person is even more stressed than they might have been to begin with? So, here I have this idea that when we talk about PMADs, what we are considering is this is a low incidence, high prevalence of these conditions. So what I mean by that is when we look at this table on the right, you see incidence. So this means onset, first time people are experiencing these conditions. It's a relatively low rate, right? So we're seeing we're seeing like 3.9% for anxiety disorders during pregnancy. But when you look at prevalence, it's 15.8%. So much, much higher. And overall, the other point I want to make here on this slide is how much more common anxiety disorders are in the peripartum than depression. And in fact, there's, anecdotally, I will say, and I think there's also some data on this as well, that often the presence of depression, particularly when it's occurring with anxiety, is an indicator of severity. And often when we treat the underlying anxiety disorder, you will see depression remit. So this is my plug here. Although, of course, especially postpartum depression, when we're trying to help someone to bond with their new infant, is incredibly upsetting and something we really need to be focusing on. And I don't in any way mean to discount that, but we really need to be paying attention to anxiety as well, because it can be incredibly disabling here and may also lead to depression. So when we look across anxiety disorders as well, the three that we tend to see to occur most commonly in pregnancy and the postpartum are specific phobia, social anxiety disorder, and OCD. I think particularly social anxiety disorder and OCD make a lot of sense here. So social anxiety disorder, if you think about this, you're going to have a lot more contact with medical professionals during this time. Some of you guys may have seen the Surgeon General's report come out this week on parental stress. And one of the things that they highlight is sort of this shifting expectation we have of parents to really be custodians of their child's life and to really get them involved in sort of academics and sports and things like this early on as contributing. And I think one of the pieces that may not have been as clearly highlighted there is the judgment we have of parents when they disagree about parenting style. And so I think it makes sense to me that social anxiety disorder has onset during this time. If any of you have children, get a lot of feedback from people around what the right way is to parent even before the baby comes. So I think that's where we see that bump up happening. With OCD, we know in general, you'll see right here that I don't know if you guys can see my mouse, but around in the peripartum, we see numbers of about 3.9%. It's higher, more common in the postpartum, so after baby comes. And these types of obsessions that people experience here are often around harm coming to the baby getting sick, the baby getting kidnapped, SIDS, accident or injury occurring to the baby, dropping the baby, shaking the baby, or harming the baby yourself. People will at times also have sexual intrusive thoughts while breastfeeding that are very distressing to them. The important thing to keep in mind with peripartum OCD is that there is distress present and anxiety, right? They're worried that they might harm the baby. This is different than a delusion where, for example, like Andrea Yates, horrible stories we've heard in the news about peripartum psychosis. Peripartum psychosis is zebras. It is much less common. Perinatal anxiety, perinatal OCD are horses. That is much more likely, but it's really important to understand when you have that thought about hurting your baby, drowning your baby, shaking your baby, how do you feel? Are you anxious, or do you feel like this is maybe morally the right thing, or that you're being told by God to do this thing? So really clearly understanding how the person feels when they have the intrusive thought is very, very important here. So who is at risk? Again, the number one best predictor of who goes on to develop a perinatal, that includes pregnancy and the postpartum mental health condition, is their preconception mental health history. So knowing, and this is something if you work in an integrated care setting, really encouraging the medical providers that you work with to have a really good full history, including the person's mental health, is important for knowing who's at risk. Other risk factors include all of our social determinants of health. So, whether the person is living in poverty is very significant, whether they have, spouse or partner support, whether the pregnancy is wanted or not, regardless of whether it's planned. I do want to point out that 50% at least of pregnancies in the US are unplanned, right? They're not intended pregnancies. And when we are seeing these increasing rates of difficulty with accessing abortion care, I think we're going to be seeing increasing rates of perinatal mood and health, perinatal mental health conditions in general. Also of note, Gen Z is twice as likely as boomers and older generations to be affected by a perinatal mood and health, I can't get these words out, a perinatal mood or anxiety disorder. And I think, again, this is, in my mind, likely related to the overall trend we're seeing in terms of teen and youth mental health, where we are really seeing dramatic increases in rates of feelings of helplessness, hopelessness, depression, and suicidal ideation, unfortunately, in teenagers. And I think that's now translating as they're coming of age and having children. I think they're at increasing risk for a variety of reasons. So why does it matter? I think since you all are here, hopefully you're already on the same page with me that it's really important for us to be paying attention to perinatal mental health. Just a few things to point out. And again, one of the reasons why I really care a lot about intervening early is that we know that depression and anxiety during pregnancy and also stress, particularly something called pregnancy-specific stress, get under the skin. And what I mean by that is they have biological health effects for both mom and baby. So when women report high levels of pregnancy-specific stress, depression, and anxiety, there are associations with preterm birth and low birth weight, even after we control for maternal health. So something is really happening at a biological level, whether it's related to increased susceptibility to infections on mom's part because of stress, early rises in cortisol levels. Cortisol and progesterone increase over the course of pregnancy, so maybe it contributes to an increasing escalation in cortisol, which precipitates preterm birth. Cardiovascular risk factors. There's a lot of ways this may be happening, and we still need more research in that area to better understand it. But if we get in there early to intervene, now we have an opportunity to convey some health benefits to baby potentially as well, as getting mom in while she maybe is a little less stressed because she doesn't have the new infant at home. So again, untreated maternal mental health disorders, also we know that especially women who are depressed, are more likely to have difficulties with attachment with their infants. And we also see effects on things like child risk for internalizing and externalizing disorders, particularly conditions like ADHD, and child depression as well. And we know that there is also a huge economic cost here of us not adequately supporting new parents. Which I think, again, like we are seeing, this is the Surgeon General report here on the left, and I encourage you guys to take a look at that. We see some of the factors that they're pointing to and what we're now calling the parent mental health crisis. But there's never enough time, sort of all of these increasing obligations we feel to try to prepare our children for college, for example, which is increasingly seen as sort of a requisite to being able to make enough money to live a healthy kind of middle class life. And then also some of the other things that are going on politically and environmentally right now with, for example, police shootings, just other things that are occurring in context. These are things that are also affecting people during the peripartum. It starts before they even give birth. Just as I think this is striking, this is some of the data from the annual morbidity and mortality, or I think quarterly morbidity and mortality reports that come out. This came out last year, looking at 2017 through 2019. And you see here that in terms of risks of pregnancy-related deaths, particularly in the postpartum, that maternal mental health conditions are the top risk factor for maternal mortality in the postpartum. We know that pregnancy is protective against suicide while the person is pregnant, but about 20% of maternal deaths in the postpartum are related to suicide. And I think sometimes that's difficult to disentangle from drug overdose, whether it be intentional or not. But I want to point out that postpartum period is a period of increased risk for loss to suicide. So why do we have this problem with maternal mental health in the US? One big issue is just how our health system is set up. We don't do a good job of screening at all. And in fact, the American College of Obstetrics and Gynecology, ACOG, really didn't even have guidelines for screening for maternal anxiety up until 2023. We only had guidelines for depression. We weren't even looking for it systematically. So that's one of our big issues. Just the time pressure that physicians are under. It's interesting because this is a time in people's lives where they may have a lot more contact with the healthcare system. But again, those contacts tend to be very brief and are maybe focused on, medical problems that the person is experiencing related to the pregnancy. And so it can be difficult to make time for screening. And so less than 20% of women are screened for a mental health condition during their pregnancy or the postpartum. Most people have very limited contact with their providers in the postpartum as well. Here at Stony Brook, they have 1 6-month visit and their one 6-week postpartum visit with their obstetrician. And that is show rates for those visits are very low. And so a lot of it falls on the pediatrician to be screening parents. So having good relationships with pediatricians, being connected with mental health care is important. So why are we failing to screen and refer? We don't have really good systematic prescriptive guidelines for therapy and medication. So we now at least have the ACOG guidelines that encourage screening, but then what? What do we offer? We really need what I would consider kind of a nomothetic, meaning we're using statistics, we're using facts to kind of guide who we recommend receives what services. You guys, I'm sure, are aware, we do not have enough psychologists to see everybody for long-term therapy, even though that's increasingly becoming popular, at a cultural level. It's just not possible. It's not feasible. So, having stepped care models, utilizing things like collaborative care, I'll talk a bit more about. There's ways to extend access to care in that way. But if we don't have guidelines about who to offer what services, our physicians are really flying blind. There's a lot of lack of knowledge on the part of even providers. A very common thing we run into in the Stony Brook community is women coming in and saying, my psychiatrist found out I was pregnant and immediately stopped my medication. That is not safe. That is not healthy. There may be a need to change medications or dosages, but that should be done systematically, and abruptly stopping somebody's medication is a problem. Especially for people with severe depression and bipolar disorder. Those conditions in and of themselves are considered teratogenic, meaning if they are not treated, they can confer a risk for birth defects. So we really need to be thinking about, how we can also educate community providers about medication and medication safety in pregnancy. So there's just really a lack of referral resources, a lack of people with expertise in this area, whether it's therapists or psychiatrists, can be very hard to find in the community. And I've really run into this personally. I work very closely with our OBGYN department, and I was talking to one of our physician leaders in that department, and he looked at me and he said, why would I even ask them about their mental health? I don't have anywhere to send them. I don't have anything to offer them. Really concerning. So we really need to start building more partnerships and utilizing models like integrated care, collaborative care, and stepped care that can help us to reach more people. The second problem we really see is related to patient preferences and sort of a mismatch between the services we have to offer and what people are looking for. There is a lot, if you talk to women who are pregnant, there is a lot of self-stigma around maybe being worried about having a mental health condition. A lot of women are very fearful. I've even worked with people that have had a previous pregnancy where they experienced depression and they assume that they're going to experience it during their second pregnancy. I even had at one point a patient who was seeking to terminate her pregnancy because she was so fearful that she was going to experience depression during her second pregnancy because she thought it was just biologically inevitable. So there's a lot of kind of myths out there, even among people that are pregnant. A lot of self-stigma. This is supposed to be the happiest time of my life, and I'm not happy. That's a really hard thing to admit. A lot of times people are very concerned about how their OBGYN or the person who asks is going to respond if they admit that they're experiencing depression or anxiety. There's a lack of knowledge about therapy. If you're a practicing therapist, you know this. People think that, it's talk therapy, that I have to be in therapy forever, and are not aware that short-term psychotherapies like CBT can be incredibly effective here. So, people need to understand that. There's a lot of people who have a preference for individual versus group therapy. I'll show you guys here in a moment. Some interesting work that was done a while back at this point, back in 2009. So some of this may have shifted a bit since then, but looking at people who are pregnant and what they would like in terms of accessing care. And it's a problem that we have to think about how to confront. And then lastly, practical barriers, time, transportation, childcare. And I'll show you guys some qualitative research that our group has done that kind of elaborates a little bit on this. So when we look at, this is folks that were pregnant with depression, and this was a group, Goodman did this research, asked what type of therapy would you be, or, resources would you be interested in? What's your first choice? What's in your top 3 choices? The majority of people here you can see are preferring individual psychotherapy. Again, when we think about the lack of access to therapists, that's difficult. We also know that women really benefit, and again, I'm using the term women, but pregnant people really benefit from support from people who are in sort of the same phase of life. So people who are either pregnant or have young children. That social support is really important. And yet we see people here that aren't interested in group therapy. You see, was only the first choice for 1.1% of the population. And I think some of that, or sample in this study, I think some of that relates to understandable, want to have a one-on-one connection with somebody to be able to talk very specifically about your problems. But I think it also ties back into this stigma problem that we're seeing, that people are afraid of sharing, but may really benefit from sharing some of the experiences that they're having in this transition to parenthood. Again, web-based internet support. This was from, again, 2009. So I'd be curious if we did this work again to see how much that shifted. But I anticipate it might be a little bit higher, but we did in some of our qualitative work have people express a lot of skepticism about internet resources in pregnancy that I think may interfere with them accessing high quality resources that may be out there. This is also looking at the acceptability of different types of interventions. Again, same message here, that people really find individual counseling to be the most acceptable. And people are very fearful about breastfeeding and medication and pregnancy and medication. And so being able to really dispel some of those myths about the safety of medications. You don't have to be a psychiatrist or a medical provider to be able to do this, to say that there are medications that are safe to use during pregnancy and during breastfeeding. It is a risk-benefit analysis. But don't just write all of those options off, because it may, especially if you're experiencing severe depression or a severe anxiety disorder, be beneficial to you. So risk benefit. Problem 3. This is one that's really important to me, the hormone myth. I'm going to put it out there up front. I'm going to really, make a pretty strong case here. This is not meant to say that hormones are not part of the picture with postpartum depression, with anxiety disorders in this period. Certainly hormones contribute to mental health problems. I do not want that to be the takeaway message. What I want you to instead take away is that they are not the single cause of these types of problems. There is, in fact, no human data prospectively, meaning we cannot predict based on somebody's estrogen or progesterone level their risk for postpartum depression. We just can't. We've done it in mouse models, but all of the drug development that's currently being done is based on the assumption that dropping levels of progesterone and associated metabolites that happen when a person delivers, your progesterone levels increase throughout pregnancy and then precipitously drop after delivery, that is in some way triggering depression in the postpartum. What we know is that stress plays a tremendous role, even for people who have a very strong biological loading. There are things that can be done to prevent postpartum depression from a behavioral perspective when we understand that. When we don't understand that, it leads to folks like the patient I mentioned who came in and was wanting to terminate her pregnancy because she was certain she was going to experience depression again. And it prevents us from having that opportunity to intervene early and prevent some of these problems. So we really need to be just really moving away from this idea that postpartum depression is the only thing we need to care about and that it's only caused by hormones. So what does cause maternal mental health problems? I really like to think about this from a kind of diathesis stress perspective. Of course, biological loading, health risk factors can really, personal coping styles. There are kind of these underlying risk factors that may pre-exist. And then we have the stress piece, which is giving birth. Folks who are clinicians know that it doesn't matter how happy you are about becoming a parent. If you are sleep deprived, if you don't have enough money, if you're getting hit with huge medical bills, you're going to experience stress. And if you have an underlying tendency, you're also going to be socially isolated, not having adult conversation. I cannot tell you how many moms are actually happy to go back to work sometimes because they're going to get that adult social contact. So we underestimate the role of stress because it's supposed to be such a happy time. So we need to be thinking about both risk and resilience factors. We know in terms of things that convey risk, avoidant coping style. Pregnancy-specific stress, which is that worry about whether, the health of the pregnancy, labor and delivery, and parenting. And we know that that's particularly pernicious, get my P's out there, particularly pernicious in terms of risk for low birth weight and preterm birth as well. So we also need to be paying attention to stress, not just anxiety and depression. Other risk factors, domestic violence, one of the leading causes of maternal morbidity while people are pregnant is homicide. It's a sad story, but it is something we need to be aware of. And food insecurity, things that promote mental health resilience, an active problem and emotion focused coping style, maternal optimism, so having kind of a positive outlook, as well as that social support, particularly from peers who are in the same phase of life. So, I just have this in here again because I like to always think about the health connection as well for thinking about intervention and making sure we're really targeting what we need to. So we really need to be paying attention to that elevated prenatal maternal stress and that pregnancy specific stress and thinking about sort of the biobehavioral mechanisms for how it gets under the skin. I mentioned some of those already. So susceptibility to infection, cardiovascular problems, preeclampsia, that stress may be kind of more directly contributing to. But if we think about it when we're stressed, how does that affect our health behaviors? And this is a time in our life where, there's increasing demand on us to be taking care of our body, to have a healthy pregnancy. And that is really difficult for some people. So making sure that when we're working with people and we're doing cognitive behavioral therapy or interpersonal psychotherapy, that we're paying special attention to things like, are they smoking? Are they drinking or using marijuana, which we're increasingly seeing as problematic in this population, to cope with their stress? Are they exercising? Are they doing the things that they need to? We need to pay attention to those health behaviors as well to help prevent some of these adverse birth outcomes and increase parental resilience themselves too. So what do we know about what kind of behavioral interventions work in this population? The most support we have is for CBT and for interpersonal psychotherapy. I really think even when we're doing CBT, really focusing on social connectedness, making sure people have adequate social support and good communication skills is essential. We know that gender roles become more pronounced oftentimes in the postpartum, where women are taking on a lot more responsibility for household tasks, in addition to now being, responsible for childcare. And that can be really stressful. We know that marital dissatisfaction, relationship adjustment suffers often in the postpartum. So really making sure that we're addressing that social connectedness component's essential. We also know, again, that stress is a big factor here. And so there may be a lot of room for mind-body techniques. And there's some preliminary evidence out there for yoga and mindful meditation. But the experiences that women have during pregnancy are really complex, the psychosocial needs that they have. So likely things like yoga alone or mindfulness alone are not adequate to address the needs of somebody who really is showing some of these risk factors we just mentioned. They really need a more comprehensive intervention. And we just have a lot of issues with the existing research. I'm not going to go through all of this in depth here, but I will just, mention the fact that the quality for some of the literature, the complementary and alternative medicine literature on things like yoga, Tai Chi, some of these other interventions, is the quality of the work is not that great. So I think we really need a better, these types of providers that are doing this work need more support from the scientific community and effectively evaluating their work. And that goes both directions. We need to be reaching out more to these folks as well to really leverage what they can offer. I also want to point out here that follow-up with this population is brutal. I'm going to show you guys a little bit of data from a clinical trial that I did over the past few years, and it was very, very difficult to stay connected with women. And we know that follow-up in the postpartum, if you intervene during pregnancy, making sure that women still have access and connectedness in the postpartum is essential. And yet we're really losing these participants. It's hard to keep them, and these clients, it's hard to keep them engaged. So we had a study we called Calm Mom. This was my trial that was funded by the NIH. And we looked at a program called SMART, which is Stress Management and Resiliency Training. It was a study, I think, that had an interesting design. We had a mixed methods approach. So we did some qualitative work first to try to understand what the real needs are of this population from more a bottom-up perspective, that we were actually talking more directly with the people we were trying to develop a treatment for. And so we did focus groups with both pregnant and postpartum participants who had reported elevated stress during their pregnancy. Sorry, I'll come back to that one. So just some of the things that folks said that I think were important. They talked a lot about difficulties navigating just changing, family circumstances, a lot related to just financial barriers. So not having access to childcare, we had one person who talked about she was basically living in her parents' garage and was worried that there were like gas fumes that were going to be harmful to her pregnancy. So there really are a lot of very practical barriers that people may experience here financially. Even folks that have good insurance, walking out of the hospital with a $30,000 bill after the fact, it's very, very stressful. A lot of concerns about being a good mother. So I think this ties back into some of what I was saying about the Surgeon General's report, that this is really, there's a lot of pressure on parents. And I think we would see the same thing to some extent in fathers or non-birth parents, that, I may not be a good parent. What does it mean to be a good parent? How can I parent multiple children if I have them? So this one person saying, when I was pregnant, it was like, if anything goes wrong with the baby, it's my fault. Even if it's not my fault, it's going to feel like it is. I'll eat the healthiest breakfast I've had in years and my sugars will be up. This is a person that had gestational diabetes. And it's like, what the hell? So after a few months, I'll be crying to eat a popsicle. So this also having to sort of subsume your own needs to those of the fetus or the baby is a big theme. And how do you adjust to that role of now having somebody else in your life that you may want to put first? And how do you also still care for yourself? We heard a lot about loss of just autonomy and control, like feeling like as you're pregnant, your body no longer belongs to just you, whether it's people touching you or commenting on you and your looks or your weight. It's very difficult for folks during this time. Also, just a lot of lack of support or control around their occupation. We heard consistently, and I hear this from clinical patients all the time as well, that and even my coworkers at Stony Brook, to be quite frank with you, that I don't know what I'm entitled to. It's very hard to navigate HR systems and find out, how do I get access? What are the paid, family leave laws like? How have they changed? How do I going on disability for part of time so you can take longer leave? It can be very challenging logistically to navigate those systems. We also talked to them about really the barriers to care. So one of them really came down to feeling like they actually had behavioral control, that they could actually seek care, especially therapy. So this person said, I'd like to take time off from work, but it's difficult, especially if you have to save up all your time for when you're actually out. So this person did not have access to leave and had to use their own vacation and sick time. Other people talked about sort of just norms. And again, this internalized stigma we talked about. This person was really worried that, if she talked about needing time off to go to therapy or, extra medical visits, that they would say she couldn't do her job. This was a person that worked in more of a sort of a male-dominated industry too. And then there were real concerns about just lack of knowledge, that people just really didn't know, what treatments were available to them, what would be effective. Not knowing there might be benefits to counseling, thinking that medication might be the only option was something we heard. So the program we adapted here for the clinical trial I mentioned is called SMART. So this is stress management and resiliency training. It's based on some of Herbert Benson's work, who was out of Massachusetts General Hospital, kind of contemporaneous with John Kabat-Zinn. It focuses on teaching people methods for eliciting the relaxation response, so activating the body's parasympathetic nervous system, that rest and digest system, which can really be activated through a lot of different meditative and contemplative techniques, enhancing sort of awareness of what your stress triggers are so that you can then use skills to cope with them, and then developing a range of different adaptive strategies. So we mentioned the importance of maternal optimism. One of the benefits of SMART is it really focuses on not just sort of cognitive restructuring like we would see in CBT, but really positive perspective taking. It again focuses on development of healthy lifestyle behaviors, which we talked about if we're going to intervene during pregnancy, may be particularly important. Reappraisal and coping, so some of that positive perspective taking, adaptive perspective taking, and then social connectedness. So we felt like this intervention naturally already was a pretty good fit to the needs of this population. The main ways we adapted it was making sure that the health behaviors that we talked about fit the needs of people who are pregnant. Sleep was one we spent more time on, really making sure that we talked about how to get restorative sleep, especially later in pregnancy and then into the postpartum, and how to maintain the use of some of these strategies like the relaxation and mindfulness strategies when you're doing things like breastfeeding, when you're up in the middle of the night. How do you kind of adapt these strategies when you may not have the time or the kind of cognitive capacity to do, a lengthy seated meditation? Other things, that we did, we've really focused on online recruitment and delivery. We were really hopeful that since that 2008 research was conducted, that people would be more open to online treatments. And we did get people engaged, but I still think there's a lot to be said for face-to-face treatment delivery. And I think that was one of the difficulties we had in retaining people and kind of helping them connect with one another. I mentioned too that a lot of our participants talked about being very skeptical of online treatment programs. A lot of people also had a lot of experience with unmoderated forums where people are kind of sharing all of their fears about their pregnancy or really kind of like unscientific advice on health. So just a lot of skepticism of anything online that we saw in this population that I think is a challenge. But maybe something we can overcome through these types of interventions, like directly being prescribed by a medical provider. We focused on non-mental health branding. So we talked about it. This is be a calm mom. This is about reducing your stress, having a healthy pregnancy. We did not talk about depression, anxiety. We did not talk about it as psychotherapy, specifically because we were concerned about stigma preventing people from even engaging with the intervention to begin with. We focused a lot on adaptive perspective taking. We integrated a lot more on interpersonal communication, particularly with partners or other family members that might be engaged in childcare. We talked about, again, that the adaptations to health behaviors, and then really focusing on making these relaxation exercises we were teaching them to do something they could do, like doing mindful tummy time, doing a mindfulness practice while breastfeeding, some ways to make it more easily translate into activities they would be doing, taking a mindful walk with the baby in the postpartum. So this was a feasibility trial. We had about 60 people enrolled. This was originally going to be an open trial, but we ended up doing most of the work during COVID. So we felt like we had to provide some support for people. And so we had a support group as our control that had a little bit of health education as part of it. And you can see here, we kind of had a signal that what we might be doing would be helpful, but I think we were underpowered for one. And again, we had a lot of difficulty even getting people to complete self-report assessments as part of this trial. Again, it just speaks to how overwhelmed this population is. Asking anything additional of them is very, very challenging. And so were I to do this work again, I would really simplify our assessment battery a lot more. And that's something we need to be thinking about clinically as well, that even some of the traditional homework assignments we may be assigning in CBT can really be a lot for this population. But you can see we had a little bit of a randomization issue, which is not unusual. So we had slightly higher baseline rates of pregnancy-specific stress in our SMART group as compared with our support group. But we did see a decline in symptoms, a more precipitous decline in symptoms in the SMART group. So they were less stressed at the end of the intervention this was prior to giving birth, than we saw in our support group, which basically remained stable throughout in terms of their level of pregnancy-specific stress. We also looked at perceived stress, which is a little bit different, so just general perceived stress, and we see the same overall pattern of a more precipitous decline through the sort of length of the trial, which is through time 3. This right here, I just want to point out that those gains were maintained following discontinuation of the program. So when we followed up with them 3 months, 6 weeks later, they were reporting, pretty comparable stress levels to what we saw at the end of the intervention. So I think there's a signal there, but we really had very, very poor retention in the trial. We were really only able to retain about 50% of participants through that 6-week postpartum follow-up. So I think, we really need to be thinking about more creative ways to reach this population. Less is more, less is more. We need to look at whether we can lower sort of the intensity, the dose of the intervention. We need to really think about existing services that people are receiving. So I'm really interested at this point in looking at integrating this intervention and similar interventions into things like centering pregnancy, which are group-based medical visits. I think there's a lot of room for us to incorporate these types of interventions into those types of programs. I'll briefly go back to a previous slide if I can get to it here. There was an earlier project that I was involved in that was actually designed as a prevention trial for perinatal OCD. And we recruited people that were sort of a selected population. So these were people that reported higher obsessive beliefs. So beliefs like I should be able to control my thinking, I'm responsible for preventing harm to other people. So some of these beliefs that we know can increase risk for OCD. And we enrolled them in either just a regular traditional childbirth class, or we enrolled them in a childbirth class where we added some psychoeducation and some activities to teach them how to do an exposure, to teach them how to kind of challenge problematic thinking, to teach them what OCD was. And what we saw was that the prevention group had significant decline in sort of OC symptoms from 1 month postpartum to 6 months postpartum, where we did not see a decline in our control group. So indicating that maybe equipping people with some of those skills may prevent the onset of OCD. We didn't see anybody develop OCD during this trial. Again, it's a relatively low base rate here, but I think these are translatable skills for other types of problems with anxiety as well. So I think there's a lot of room for integrating mental health into prenatal care that they may already be getting in ways that can reduce the burden on this population for accessing care. So that's really on us to partner more effectively with our medical colleagues. I think there's also, I just want to highlight, I think some of the most well-known work that's out there is Project Rose, which has really been looking at initially what we would call a selected intervention. So it was really looking at people that had risk factors, so who were living in poverty and intervening. And so they're doing some work to look at whether that type of intervention can be delivered universally, kind of preventatively, and whether that may be something that's, cost effective and might work better in workflows for clinics so that everybody is receiving access to these types of resources, or whether, we need to be thinking about really being better at equipping our medical colleagues to identify people who are at risk and make effective referrals. So something just to keep an eye on. I think I'm looking forward to seeing more work from that group. So shifting gears just a little bit, I took a pretty strong stance against biological causal theory of postpartum depression. Again, I want to say there, I think, is absolutely a subgroup of people where biology is really key. We just don't know how to identify them at this point. I think it's a subgroup of people who may be more sensitive to that drop in progesterone than others. So really a history of PPD is important, of postpartum depression is important to pay attention to because they may be part of that susceptible group. But how do we identify people who are nulliparous, who don't have other children, who have not had this experience before, what their biological risk is? There's not a blood test we can give to see if that's the case. So that's just sort of my PSA there. The two drugs that have come out, one is brinaxolone. Just before I talk about these specific new drugs, excuse me, antidepressants in general have a good safety profile for pregnancy and for women who are breastfeeding. But again, finding somebody who can consult on these things and is important. And finding a prescriber who's comfortable can be challenging sometimes because of, OBGYNs are some of the most sued class of medical professionals that are out there. And so they can be relatively risk averse, unfortunately. The new drugs I just mentioned, there's two. There's brinaxolone and there's Zurev. Can't say that one effectively. Brinaxolone was approved by the FDA in 2019. It is a natural neurosteroid that is believed to affect levels of preganolone, which is related. It's basically a metabolite of progesterone. So we know those AP levels drop in the brain in the postpartum. It's supposed to kind of restore those levels of AT in the brain, which then in turn regulate GABA, which is involved in some of the inhibitory processes in the brain. I'm going to say zuranolone because that's easier for me to say, as an oral medication that was approved in 2023. It's a synthetic version, so they were able to make a pill formulation of it. Again, is thought to have a similar mechanism of action, though. My concern with these two drugs is both of them have kind of 2 to 3 industry-sponsored trials, and they both result in pretty rapid reductions in depression symptoms in women in the postpartum. My biggest concerns are that the reductions were not that much different than what we saw in the placebo group, and the placebo was just a sugar pill. They weren't even receiving therapy. It wasn't even another medication it was being compared to. And there was like a 2 to 3 point difference on the HAM-D, which is what they were using to measure depression, between the placebo and the actual drugs. So how well do these medications actually work? They can be quite expensive. Getting insurance coverage for them can be problematic. The other concern is that side effects may be pretty pronounced. If you look at this is for the drug, for the pill. And what we saw was about a quarter of people were feeling sleepy, especially on that 50 milligram dose. It can be quite sedating, and that is not something that new parents need to be experiencing. And again, these have only been trialed in severe depression. So we really don't have sort of a medication-based option for mild to moderate depression right now that we can feel confident in. So I think there's a lot. I think we need to work on this area. I think drugs like this could be really life-saving for people with severe depression, but I don't know that we're there yet in terms of having something that really works so that we understand. And you notice I said throughout here, believe to restore, believe to work. If you look at the actual FDA approval, it says mechanism of action unknown, which is a problem for a lot of our psychiatric medications that are out there. So lastly, future directions, what can be done? Screen with validated measures. Really make sure that we are actually connecting people that screen positive with care. We know depression can worsen, anxiety can worsen if we screen and don't refer. We need to look at things like collaborative care, integrated care, stepped care, develop partnerships if we really care about this area with providers in our area so they know where to send people. We need to be using training, other staff, postpartum doulas, and nursing and behavioral interventions, and thinking creatively about how to reach this population through, for example, group-based medical visits and incorporating mental health care into those types of approaches. And we need, lastly, and I think most critically, need to develop clear treatment and prevention guidelines like they have in the UK and Australia. We should be able to have providers write a prescription for 6 sessions of CBT. That doesn't exist in the US right now. We still treat medications as the frontline treatment when we know behavioral treatment should be the front line for mild to moderate depression and anxiety. And just a thank you to the folks I worked with. So I will stop there, maybe have a few moments for questions, and then I'm more than happy to be available via email. However, you guys would, I'm available and happy to connect with anyone who has more questions. Right. I'm not sure for Chris, I'm not sure which table you're referring to, but I'm happy to make my slides available. Maybe you're referring to the Goodman 2008 table, or
It was the first two that you showed.
the first two.
that
Those
you
are
did.
from Nicole Fairbrother, and I think 2013. 2013, yeah. Happy to answer any questions.
Megan just wrote, any correlation between perceived experience trauma during birth and depression, anxiety outcomes?
So absolutely, we know that there's a significant number of women who experience birth trauma, and I think is also more common among people of color, and that certainly is associated with risk for depression and anxiety in the postpartum. A lot of people qualitatively in our sample also talked about experiencing just kind of invalidation, especially from healthcare providers, that was significantly added to their stress burden.
Thank you. And Nick Murray wrote, are there opportunities to explore SMART with Spanish speaking and other languages in this population? Which is a great question.
Yeah, I'm actually involved with a trial of SMART right now where they're translating it for and adapting it for parents of children that have learning disabilities. So it has been translated to Spanish, not the pregnancy specific version of it. That's certainly something we could look at down the line. But I think that there's a lot of overlap with that trial with parents of children with learning disabilities.
And then Lauren wrote, any evidence-based recommendations for observing sleep hygiene during postpartum when many birth parents are encouraged to wake frequently throughout the night to breastfeed? This has been a big concern also within my own practice, where they're telling parents to wake up every 2 hours.
Yeah, so for those who may not have children or not, if they have this experience, a lot of infants lose weight early after they come home. And so often they're encouraging regular feedings because the baby's stomach is too small to process enough nutrition. Yeah, I don't think that there are any evidence-based recommendations for that. And I think it's something that parents have to kind of figure out how to cope with. One of the things I do clinically with new parents is I'll talk a lot about like coming up with sort of a schedule where if you have a partner, not everybody has this luxury, but if you have a partner where you kind of take shifts so that the parent can have you can have a little less sleep disruption. We do know that sleep disruption, there's some evidence that for some people when depression when sleep starts to get better, depression also gets better. So there may be causal links there that we don't fully understand. So I really spend a lot of time with new parents on that. There's no straightforward answer though. It's really challenging for a lot of people.
Okay, we're right at time and I have closing remarks. I want to thank you so much. And I'm hoping we can see you again because this was incredibly informative. I'm sure there are more questions. So post on our listserv, reach out to Dr. Mahaffey. We'll just keep these conversations going in terms of APA's closing remarks. So thank you for attending. Remember, if you would like CE credit for this event, please respond promptly to the evaluation link, which will be sent via email shortly. We'll leave the evaluation open until Friday, September 27th. CE certificates will be sent via email within 5 to 10 business days after the evaluation period closes. And remember, you're encouraged to submit an evaluation even if not seeking credit. And feel free to email us at admin@societyforhealthpsychology.org if you have any questions. again, thank you, Dr. Mahaffey, and thank you everybody for attending.
Thank you so much.